Well, thank you for that kind introduction. It's always great to be the out-of-town speaker. You get introduced, people say nice things about you, and then you get to get in the car and get away. I will tell you a little bit about how at least my part in this wonderful event came about. I got an email 6 weeks ago, maybe something like that, from one of your members, a woman named Nancy Rudner. Nancy and I have known each other for more years than we admit anymore, but we don't really stay in close touch. And so this email kind of came out of the blue and said, "Do you have some time to talk by telephone? I'd like to talk a little bit about some health policy questions and maybe ask you a question." So I said, "Sure," and we made an appointment and we got on the phone and we started talking. And Nancy, and we professors, we're supposed to be skeptical and kind of thoughtful, but Nancy jumped right into, if I remember the last time we were talking, I think I remember getting the clear impression that you're a very patriotic kind of guy. And I said, "Yeah, I think I am." She said, "Do you believe in the Pledge of Allegiance?" And I said, "Yeah." She said, "Do you believe in the Constitution?" I said, "Yeah." She said, "Do you believe in free speech?" I said, "Yeah." She said, "Good. It'll be in Orlando on May the 8th at the League of Women Voters." And I took it hook, line, and sinker. I mean, it was what I was asked to do today really, I think, captures in some ways how subtle and nuanced this area of Medicaid and Medicaid expansion really can be. And in a few minutes, we're going to talk to a group of panelists who know way, way more than I do about how this stuff impacts their various programs with their clients on the ground in Orlando. My job here is really to paint a much broader picture of the world in which they try to accomplish those things. So, I'm a professor. I can talk for an hour on one deep breath. I promise I won't do that. So here are kind of the objectives for our meeting today. I have an assistant who makes these slides for me. She's taken courses in how to do slides, and I don't know. I used to have this great big green gator head for my first slide, and people got mad about that, not the least of which was the Athletic Association, because we're not actually allowed to use that big green gator head. But I managed to get that watermark in there, so don't tell anybody. So I'm going to set a context for us, then we're going to hear from our panelists, and then we really very much want to hear from you. The key issues in healthcare and healthcare delivery in the United States, and for that matter in all of the rest of the Western world, really don't change very much. We're in this constant battle of how much quality and how much cost and how much access are we willing as a society to invest in. And there is some kind of expectation that we can't do everything for everybody all the time. There was a wonderful book written 40 years ago entitled "The Hospital That Ate Chicago." It's a terrible book, but it's a wonderful title. And it really does capture this idea that if we delivered every conceivable health care opportunity to every one of us all of the time, we would break the bank. So we have to kind of balance among these three things what we really want as a society to accomplish. The problem in the United States is that on all three dimensions, we're way out of whack. That's a technical term, out of whack. We pay by far the most for our healthcare. We have the most expensive healthcare system in the world. We're Gators, we like to be number one. We don't want to be number one on this, but we are. And there's a huge distance between us as number one and number two. So we have ridiculously expensive health care in the United States. And we don't even come close to getting the highest possible quality returns from that huge investment. And most of us, we know some things are more expensive. We buy a Mercedes, we expect it to be better than if we buy a Ford. But if we buy a Mercedes and we get a Ford, we're not too happy about that. And that is the situation. And then finally, we have this highly variable access to care, where our panelists will be able to tell us a little bit later. We've got literally millions upon millions of people in the United States with almost zero access to medical care, and others who could have anything they want this afternoon. And that kind of absurdity in terms of uneven access is difficult for us to tolerate indefinitely. So, why is this the case? Well, first, we just have to get a handle on the fact that healthcare really is different. It's not like shoes or clothes or housing or cars. It is not something that we can manage in a simple, what my economist friends call transactional model, in which each patient pays for that episode of care at that moment. It just can't be like that. And the reason is, it's too expensive, and it's too unpredictable. Now, we have lots of things that are too expensive for us to pay for them in cash: houses, most cars. And as a general rule, Americans like to use debt financing for those kinds of things. So we get mortgages, we get car loans. That doesn't work in healthcare because the people who run up the biggest bills, this is kind of rude, are the least valuable credit risks. In fact, there's a pretty good bet that they're going to die. And so they're not going to pay it off. Can't use 30-year mortgages for that heart transplant we need, because if it goes wrong, who's going to pay the mortgage? So we have to have some device that's not the cash economy, that's not debt financing, and that device that we have fallen upon, we call health insurance. It's probably not a really good name for it, but it's what we have chosen to do. So, this is just a long slide saying what I just did. In the American context, what we've chosen to do for our health insurance is this hugely complicated system of about 6 or 7 major components. First and foremost, we like private employer-sponsored health insurance that we buy at work. That's our modal category, the single most common approach, and it's the one, generally speaking, that we like the best. But there are lots of people who can't get that because they don't work at a place that offers it. So we also have private, individual health insurance that you buy through your local agent. We also have Medicare, targeted to elders, people over 65, and a small number of people with particular diseases or disabilities. We have Medicaid, targeted to poor people. We have focused government programs like the VA or military health insurance, military care, Champus, things like that. And then finally, we have this wonderful and uniquely American device called uncompensated care for people who don't fit into any of those previous categories. These are people who have no health insurance, but they are not immune from getting sick. They do get cancer, they get in car wrecks, they have the same kinds of health circumstances that all the rest of us have without health insurance. And we have developed this notion in the United States that they should get care and that the people who provide that care will be uncompensated for it. It is a kind of a nutty system. That's another technical term. And yet, despite how nutty it is, and I mean, when I say nutty, think about it for any other sector of our economy. Think about it for food. You go to Publix, you get your cart, you fill it up, you buy $100 worth of groceries, you get to the end of it, and the cashier says, okay, you've got $100 worth, but the bill is $125 because there's other people out there who don't have any money, and we need to gather up some extra to pay for their food. I mean, we would find that completely intolerable in aspects of the healthcare, of our economic system other than healthcare. But that's what we do in healthcare all the time. 20% of every hospital bill in the United States is targeted to pay for the health care of somebody other than the person named on the bill. Think about that. We can reduce our health care consumption by 20% in one swat if we could eliminate that uncompensated care. So, it is a nutty system, but it's ours. We're Americans. We like it. And we are determined to kind of hold on to it as much as we can. And ironically, it actually can work. Kind of. But it depends on these assumptions. All of these have to be in place for that nutty system to work. The first and most important is we can't have too many uninsured people creating too much uncompensated care. We can't have health care that is so expensive that even a small number would run a huge bill out. We have to have a robust private insurance system out there that will help subsidize the care for uninsured people. We have to widely and fairly and evenly distribute that uncompensated care across all of the hospitals and all of the doctors and all of the labs and all of the other providing sectors. And finally, we have to have this informal set of winking and nudging agreements where everybody's going to pretend that we don't have any uninsured people and we don't have any uncompensated care. And if we could get all of those assumptions in line, then our nutty system would continue to work reasonably well. But in 2008, it was very clear that none of those assumptions were operative. We had 50 million uninsured people in this country. Even those of us who had insurance, we all hated our insurance companies. I have heard more bad jokes using more bad language about insurance companies than I have about any sector of our economy except maybe lawyers and politicians. At that time, individual health insurance was very hard to get and it was extremely expensive. Employers were starting to worry about their costs and the winking and nudging agreements were being ignored. People were trying to run away from their share of the uncompensated care. And so the system was starting to crumble and we really needed to do something. The Affordable Care Act is huge, it's complicated, it's 1,500 pages, it's all of the things that you've been told it is. But at its core, it really was targeted to a couple of pretty simple principles. One, reduce the number of uninsured people, dramatically reduce the number of uninsured people. And by doing that, reduce the amount of uncompensated care so that the rest of that system of silliness might actually work. The way the Act intends to reduce the number of uninsured people and the number of, and the amount of uncompensated care is first by easing and subsidizing the purchase of private insurance through those exchanges. And Ann's going to come up in a little bit and tell you about how some of that works on the ground. Second, by encouraging more employers to stay in or get into the business of health insurance coverage for their employees. Third, by allowing young adults to stay on their family plans much longer than has historically been the case. And finally, by expanding Medicaid. And in its original form, the Affordable Care Act required all 50 states to expand their Medicaid program. Expand it to cover everybody whose income was less than 130-ish% of the federal poverty line, period. No other categorical requirements, no certain diseases, no specialized populations or groups. If your income was below that cut point, you were eligible for Medicaid, period. That's what the law says. The Supreme Court determined that it was not constitutional for the federal government to impose that expansion on all 50 states, but it did say that it was perfectly appropriate for the federal government to allow that expansion. And so the law now currently allows the states to expand their Medicaid program up to that 135% or whatever it is of the poverty level. And here's the kicker. For the piece of the Medicaid program in each state that is reflected in the expansion, not the old original Medicaid, but the expansion of Medicaid, the federal government is picking up the entire tab. Literally 100% at the beginning of the law, sliding slowly down to 90%, and then staying at 90% forever. So it's not as if the federal government was imposing the dreaded unfunded mandate on the states. They were just saying, you can do this, and if you do it, we'll pay the tab in your behalf for the expansion. So I always like to remind people, and I'm just about done, we're going to get the panel up here in a second, I know you're tired of it already, what's not in the Affordable Care Act. So there is no single payer system in the Affordable Care Act. There's no expansion of the Medicare program. There is no Medicaid or Medicare buy-in option. There's no new public program. There's no negotiated drug prices with Big Pharma. There's no new licensure requirements or standards. There's no tort reform. And these are all things that various people in the health policy conversation wanted to be in that Affordable Care Act. And there are none of them there because, like all of our laws, the Affordable Care Act really is the result of a year's worth of negotiation where people got some things they wanted but didn't get some other things they wanted, or they didn't want. Now think about those things and get a hold of this. The Affordable Care Act is really a remarkably conservative, middle-of-the-road, staid piece of legislation whose basic objective is to strengthen our existing medical care system so that we can keep it the way we like it. And the almost mindless accusations that the Affordable Care Act is socialized medicine or is a government takeover or these things are just simply not true. They're not even close to being true. And yet that is out there as part of our political conversation. So what we're doing here today is going to talk a little bit about how one part of the Affordable Care Act is working or not working in Florida. Before I get there, I do think it's important for people to understand that up until about a couple of years ago, I don't have really recent numbers, almost 20 million people got insurance through the Affordable Care Act. Most of them either through the exchanges, where people go and buy it, or through expanded Medicaid, about half each. A couple million are relatively young people that stayed on their parents' plan. And 31, I think it's 31, 37 of the 50 states have, by one device or another, expanded their Medicaid programs to align with the Affordable Care Act. Florida is not one of them, and that's part of the reason we're here. Florida also didn't bother establishing a state-level exchange, so now we are number one. We have the most people on the federal exchange of any state. Thanks to Ann and her hardworking navigators and colleagues, we are signing them up like you wouldn't believe and shipping our money out the door. As a state, Florida is the single largest contributor, and Florida remains, even with all of that purchase of health insurance through the exchanges, we're still right near the top in terms of the number of uninsured people we've got. Nationally, the uninsured rate dipped after the passage of the Affordable Care Act. It hit its low point in 2017. It has been going up since then, and the slope is not encouraging. Right now, nobody knows how to count it for sure, but someplace between 25 and 35 million of us are uninsured. And even a fully mature and really working Affordable Care Act would still leave 25 million people uninsured. Now, that's the tricky question. Is 25 million uninsured people a small enough number for the winking and nudging to start working again? I don't know. No one knows for sure what that number has to be. But it certainly cannot be the 50 million that it was when the Affordable Care Act was passed. So the issue is, why doesn't Florida expand its Medicaid program, since the federal government will pick up 90% of the tab for it? And to be fair, there are thoughtful discussions about why Florida ought not to. part of it is purely political. You know, one of the things that the Affordable Care, I'm fond of this small story. I'm going to rush up right up against my 1 minute here. The Affordable Care Act establishes something called the individual mandate. Part of the law requires that each of us have health insurance in one form or another. The individual mandate was developed as an idea for health insurance reform by the Heritage Foundation, was sold successfully to the Republican Party, and became part of the Massachusetts plan. So the individual mandate is an overwhelmingly Republican idea until the Democrats adopted it, at which point it became a completely unacceptable idea. The same thing applies in some ways to Medicaid expansion. There is a rump in some 10 or 12 states that are just basically staking out the position that we're not going to do it because it's theirs. And I don't know how much of that's going on in Florida, some for sure, but in addition to that, there are some thoughtful considerations. Even 10% of a big Medicaid budget will cost the state something. It's not free. It is a public program, so if you are philosophically opposed to the idea of people being on a public program, I understand your concern. So these concerns exist and they're reasonable, but our panel is going to talk a little bit more about how this works. I'll send these slides down. If you want decent, objective information about this, these are some sources that are helpful, or you can always send me an email. Now, if our panelists would take the stage, I'm going to tell you a little bit about each of them, and we'll proceed from that point. And I'm not even going to guess which order people are coming up with. So at the League of Women Voters, the guy comes up first. This is Kevin Sharon. Dr. Sharon is a physician, a practicing physician, has been in the Orlando area for most of his career. He's the director for many years of Orange County Health Department. He is a true giant in the public health field in the state of Florida, and is highly regarded in the world of public health, especially county public health units. He is also a faculty member in that competitor medical school at the University of Central Florida. Marnie Stallman was until recently president and CEO of Shepherd's Hope, which is a faith-based program here in Orlando. Marnie has implemented a variety of dramatic programs in the real world of your real community to provide people with care, often in the absence of insurance. And finally, Ann Packham is the Marketplace Product Director for the Affordable Care Act. So she is herself one of those navigators and trains other navigators that help people wander through a website that is complicated to see what they can purchase in terms of health insurance through the marketplace. What each of our panelists has been asked to do is to maybe take 2 minutes each to tell you the one or two things that are most important to them in their professional environments about the possibility of expanding Medicaid. And then when each of them has briefly kind of staked out that position and their view of these issues, we'll turn it over to some questions and discussion from all of you. Now, just before I let the first one speak, I can't tell you how much pleasure it is for me to be here with people who do stuff in healthcare. Now, I am a professor. My wife, and wives are like this, has a way of saying that I've made a very nice career out of not ever doing much of anything, because I study it, and I think about it, and I write about it, and I do lots of stuff like that. But I've never run a hospital, I've never run a clinic, I've never tried a navigation. These are the people who do healthcare. I'm just the schmuck who studies it, and so I'm delighted to be here with you. everybody start coming and just go down the table for that brief opening statement.
Thank you, Paul, for that overly generous introduction of me. So I'm no longer with the health department. I'm retired from the health department person. So I want to tell you two quick stories of how it would impact care in this community if Medicaid were to be expanded. I'll tell you one quick story from Shepherd's Hope Clinic several weeks ago, where I saw a lady who had been a nurse in one of our local hospitals 2 years ago, working, employed, taking care of herself, knows all this health stuff. And suddenly, her mother died. She moved into her with her mother, first taking care of her while she was sick. The sick care ended, the mother died. She lost the house, was unable to meet the bills, was no longer able to make it to her job, became depressed, and the next thing you know, she's homeless, and she's in the Shepherd's Hope Clinic. So anyone can be without health care insurance. You can have it today, and it's gone tomorrow. There is no coverage for her. She's not Medicare age. She's in that gap of an adult who's not yet able to be covered by the system. And Florida didn't expand the Medicaid. Second example I'll take from the health department, we have the infectious disease issues. And if you happen to have HIV, actually have the disease, you're covered. If you don't, for the most part, you're not covered. So two quick examples there. One would be the person who's at risk of acquiring HIV, and they need to get on this medicine called PrEP. That will help them prevent the risk of the infection because they're in a high-risk relationship, et cetera, et cetera. They really need the PrEP, but the Medicaid won't cover it because they're not yet HIV infected. That's sort of a perverse thing, isn't it? Well, the same thing happens to the person with hepatitis C, another infectious disease, which they're going to lack coverage. And if we had the Medicaid expansion, these individuals, the three that I mentioned, boom, 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 they would be able to be covered. We would prevent the high costs of hepatitis C, which are cirrhosis of the liver, liver failure, cancer of the liver, et cetera, et cetera. We would prevent the tens of billions of dollars of costs in HIV by adding more PrEP. We want to expand those PrEP programs. And then whoever, tomorrow we could have no health insurance, we'd have something to fall back on. I'll close with that.
Hi, welcome. So I want to talk about the coverage that's implied through employers. This was actually in today's Orlando Sentinel, that the Orlando job market labor force is now being reported as the largest in our current community's history. A record 1.35 billion workers are now employed in the Orlando metropolitan area as of March. That's the most recent survey data that's been available from the Bureau of Labor Statistics. And according to these latest numbers, Orlando ranks dead last among the nation's largest cities for the median hourly wage at $15.94. Wages here are lower than other major tourism cities, including New Orleans, Las Vegas, and Miami. Does anybody realize what Visit Orlando, we had the largest ranking for outranking Las Vegas for tourism numbers, and that was being touted. We also took 47th spot among the largest U.S. cities for the median hourly wage at $28.95 an hour across occupations in business and financial operations sectors, which is a huge growing part of our economy. And we rank next to last for wages in constructions and other extraction fields, and certainly that is a moving part of our economy. If we look across the communities, we see cranes rising across our communities all across Central Florida, which is another booming area. Why is that important? Well, it was already noted in part of our presentation that a good portion of where currently people are getting their insurance products from are from their employers. And one of the things that was touted at the start of the Affordable Care Act law in 2010, which provided those landmark protections that we're going to be discussing, but that was not necessarily focused on, that I want to talk about some today, was the run-up and the rapid run-up of costs related for people that were getting their coverage from employers, and the high cost of deductibles and co-payments that we are now seeing on the rise. And that is also now forcing another large contingent of individuals and families to be in that pool of people that we are seeing forced into having to deal with insurance and healthcare costs as a run-up. The average deductible and single cost for individuals and families is now rising between $5,000 and $10,000 annually, and that is now placing individuals out of reach. One of the things that we would hear often at Shepherd's Hope is they would say, we now have insurance for the very first time through the exchange, and I have a Lamborghini but no gas. Meaning that they would have the product, but they couldn't access it because the cost was so exorbitant that they were afraid to touch it. So I'm going to continue on with some of what we started with a story of just somebody I met yesterday. I was at a resource fair, and a woman came up in her 30s. She's divorced with 3 children. And so I said, well, do you have health insurance? And she said, well, I don't qualify for anything. And I said, well, let's talk through it. She's working 30 hours a week. She told me she's making $12.57 an hour at one of our large employers. But because she works 30 hours a week and they won't give her 40, she doesn't get health insurance, right? So her salary is too much for her to qualify for Medicaid, which she might have because she has young children. But it's too little to get any help on the exchanges because it's less than 100% of the federal poverty level. So she's absolutely caught in the middle. She's trying to do everything right. She's not sitting home. She's working, trying to do what she can to get her family ahead, and there's no safety net. Another woman that I worked with earlier this week was 61 years old, got a pink slip or was told to leave her job at one of our major employers after 21 years. Her health insurance is finished. She has no health insurance now. So she is more well off than a lot of people that I work with, in the sense that she had a good paying job and she had even a severance package. So for her to go on the exchange, she actually doesn't qualify for any coverage because she made too much money in the first part of the year, right? But now she has no income, and every job interview she goes to, she's not able to get a job, maybe because we have inherent ageism in our society, and she's now just hoping that for the next 4 years until she gets to Medicare age that nothing happens to her, knock wood, because she can't afford the full cost premiums on the exchange. So we have people at sort of both ends of the age spectrum, and I wanted to follow on what Marnie was saying, is that we still rely on our employers to provide coverage to our families, but there's something in the Affordable Care Act that many people know about but some don't know. It's called the family glitch. And it's one of the parts of the legislation that's least popular that has not been changed. What happens when the family glitch is let's say you have a couple, a husband and wife, and the husband has a job where the health insurance offered to him is quite reasonably priced, $15, $20 a paycheck, something like that. But to add his wife onto the coverage bumps it up to $300 or $400 a month, which is unaffordable for that family. That spouse, that woman, is not eligible for the subsidies on the marketplace, so she cannot go to the exchange. She could go to the exchange and buy coverage, but it would be at full price, which is unaffordable to the family. So there are a lot of Floridians who are working, who may have some sort of coverage through one spouse or the other, but they can't afford to get both of the couples both of the couple members covered because of the family glitch. So there's still a lot of problems that we have within our current system, that a Medicaid expansion, if there was a safety net for people who were in that glitch, or if some other mechanism for them to get coverage, would help thousands of people in our state.
Okay, I'm going to take the moderator's prerogative here and ask a couple of questions, but for those of you who have questions, it's time to start thinking about them and managing through whatever device you use here. My question is to follow up, actually, for all 3 panelists. One of the things that we've seen happen over the last 10 years in the United States is that the co-pays, deductibles, other kinds of out-of-pocket expenses that people, even if they are very well insured, experience can become prohibitive in and of themselves. One of the things that Medicaid does as a safety net is it does not have very much of that kind of activity. Is that a net positive or a net negative for the clients that you see?
Well, I mean, for us, there's a big distinction when you're working with somebody who's able to get on the exchange because of their income is quite low, and that they choose a silver plan. As we all know, they can get very low co-pays and co-insurance. But as soon as they start making a little bit more money and move out of that category, the co-pays and the co-insurance become, unattainable for them and become a barrier for them to get care. As Marnie was saying, they have the insurance, but they can't use it, or they're afraid to use it because of the rising costs, and also always the unexpected costs. As we hear about this all the time, is that you go in for one thing, and especially if you have to use the emergency room, and then you find out after they've done 10 tests on you that the anesthesiologist isn't in your network, and that maybe the specialist who came in to give you a consult isn't in your network. So again, you have insurance, but you can't use it. Whereas if somebody were on Medicaid, presumably in the hospital, if they take Medicaid, all the providers there would take Medicaid.
One of the other things, because of the failure of our state to create its exchange and the expansion, is that we have a very limited network of participating providers and insurers here. So with even the products that we have available for the clients to purchase into the networks, we have a limited pool of participants that are providing on the physician and provider side. And so even that's where the Lamborghini with no gas comment came in, which is they went to their provider manual to look up for a participating provider to access with coverage. And there's a waiting list, or they're not accepting the plan, the limited plans that are being offered at the level that Ann is able to have the client sign in on. At that silver participating level, because they're simply not accepting the clients. So we have a limited pool of providers that are not accepting the patients.
And even though the providers may accept the patients, you may not always have the cooperation from the healthcare systems. Okay, it's going to be a disparity there as well. I'll use a quick example of breast cancer. We're here in Orlando. There's a large number of women who are part of the screening programs that are offered, but they really have no access to care. They actually have to go to Moffitt, but Moffitt has a very limited resource to be able to handle that because it's based on free and charitable, but Moffitt is able to do over in Tampa. So
I had a client tell me that they actually had to divorce their wife to get her to the point after her diagnosis of cancer, to get her to the point to get her to Medicaid eligibility so that she could get access to care because of the way that their insurance program was based.
Right, just to follow up on that, specifically on cancer, the number of Medicaid patients that our cancer providers in Central Florida accept is limited. So even if somebody has Medicaid here and they get a diagnosis of cancer, the hospitals have so many that they will see that have Medicaid. After that, our closest resource is Moffitt.
And that goes back to your comment about we are very fortunate here in Central Florida. Both Orlando Health and Advent Health are particularly supportive of organizations like Grace Medical and Shepherd's Hope and the community health centers working with the uncompensated care and the uninsured. But there's a limit to what even they can do. And with the hit that the uncompensated care or LIP pool had taken over the last several years, that has shrunk as well. And so we find that those spaces that they hold out for those types of clients has restricted itself considerably.
So whether it's the silver plan and people, don't go forward and access these things that may be available to them, I just see so many missed opportunities for prevention, whether it's high blood pressure and then the stroke that could be prevented, or it's diabetes and the amputation of the foot, or the infectious disease examples with the high cost of hepatitis C medications. We're missing a whole opportunity here. The return on investment is tremendous. $5 billion for the state of Florida creates jobs. That's what happens with this expansion. And I learned years ago that for every one of us, all of us who've ever used a hospital, how many here have ever been in the hospital? There's $2,000 added to your bill on average in the hospital because of uncompensated care. That's it.
So at the back of the room, where I understand Judge LeBlanc is standing with a microphone, anyone who has questions that they would like to address to the panelists, this is your opportunity.
And questions are limited to members only, 1 minute, no soapbox.